Good afternoon. I hope that you can hear me. Um, Nothing that indicates that's the case, but I do see the messages on one side of the screen. So if you're not hearing me or you're not seeing the screen, please send a message along. So our topic today is fatigue and sleep problems in Parkinson's. I think it's fair to say that this is a common problem that hasn't really gotten the attention that it deserves. If we look back, the movement problems that we refer to as motor difficulties were well described by Dr. James Parkinson 150 years ago. But it wasn't until 1967 that fatigue even gets mentioned in the medical literature pertaining to Parkinson's. And it wasn't until 1993 that there was a research paper where fatigue and Parkinson's was the primary topic. Now, why that is, it's hard to know. Probably because it's a hard thing to describe. It's common, we all get it sometimes, you don't see it, so it doesn't get a lot of respect. Gee, it really is a common issue in Parkinson's. And I really think that the research that we're going to talk about shows that it's different in Parkinson's from everyday run-of-the-mill fatigue. As you can hopefully see on the bottom of the slide there, somewhere between 30 to 80% of people with Parkinson's have fatigue as an issue. So what does the research show us? Well, back in 2007, Dr. Friedman looked at all of the studies that have been done to date, and he summarized them. He found that fatigue was mentioned as a major issue in anywhere from 33 to 58% of people with Parkinson's. And in a little over half of them, it was there all the time, and the others, it was intermittent. In fact, a third of the respondents said that fatigue was their most severe symptom of all, and 58% said it was at least in the top three of the symptoms that bothered them most day to day. The same Dr. Friedman in 1993 did a survey of 58 Parkinson patients, 58 normal controls. So control meaning that they're like the subjects, but they don't have Parkinson's. He excluded people with dementia. Now, no disrespect to dementia, and it occasionally does happen in Parkinson's, but he wanted people who were responding to the survey who had good recall of their symptoms and didn't have trouble expressing themselves. He found some correlation between depression and fatigue, but it certainly wasn't at all striking. Indeed, he had some patients who were fatigued and had no depression whatsoever. Surprisingly, he didn't find any correlation with the severity of the disease itself, as measured by the motor problems. And the same Dr. Friedman followed these people for about 9 years. And although he found that it was, if you had it, it lasted, he didn't see a whole lot of worsening over the 9 years. So I think other people agree with that as well, that the worsening of fatigue over time isn't quite as bad as the worsening of movement in Parkinson's. On the other hand, it doesn't go away. So why is it difficult to study? It's probably because it's hard to define. We have a number of fatigue scales that have been used in the literature, but they haven't been specifically validated for people with Parkinson's. One broad approach to try to get around this problem was a scale called the multidimensional fatigue inventory. This person tried to break it down into 5 subparts. So he talked about general fatigue, meaning your everyday sort of tired feeling. Physical fatigue, meaning that it's hard for you to sustain motor activities, your muscles tire out. Reduced activities, reduced motivation, and mental fatigue as well. Dr. Zanzola used this same scale, the MFI scale, along with the depression scale in 2003, a study of 19 Parkinson patients and 19 controls. Some of them had other neurologic diseases. And he found no correlation whatsoever with age, gender, if you also had sleep disturbance at the same time. He found some aspects of fatigue correlated quite well with depression, a general tired feeling, reduced motivation, the mental fatigue aspect of it. But he found that physical fatigue and a resultant decrease in physical activities didn't correlate with depression at all. Why am I harping on depression? Just because it's a common issue in Parkinson's, and fatigue is part and parcel of depression, or at least quite frequently is. In '93, Van Halen, not the guitarist, this is a medical researcher, did a questionnaire, 90 Parkinson patients, 71 controls. He found a very high prevalence of fatigue, and he found that it really correlated with excessive daytime sleepiness. Both groups, the Parkinson folks and the non-Parkinson patients, reported that they tend to be tireder right after lunch. So that's our normal body rhythm, sometimes called our circadian rhythm. People in the tropics sort of take advantage of that. They realize after lunch is a downtime. I'm hoping you're not having trouble staying awake right now. And they'll incorporate into that into their day with a siesta or something to that effect. But Van Halen also found that it wasn't just at those times that Parkinson's people had problems with fatigue. They had it at other times as well. A study by a Dr. Volkov in 2010, slightly bigger study this time, 88 patients. And his approach was a little different as well. He used consecutive people with Parkinson's coming to his clinic, as opposed to sending out a survey and seeing who chose to answer it. When we do studies this way, it's more likely to be representative of sort of a cross-section of your average Parkinson person, as opposed to someone maybe who's likes to answer surveys. So what he looked at was something called the UPDRS-3, which is the scale used to measure the movement problem in Parkinson's. He looked at something called the Hone and Yar stage, which basically looks at the overall severity and kind of correlates roughly with how long you've had the illness. He used the Beck Depression Scale, he used a general fatigue scale, and something called the Epworth Sleepiness Scale. And in his study, he found that 59% had fatigue, 48% had excessive sleepiness in the daytime, we'll use the initials for that, and 35% had both. He found that it correlated with motor severity, although I must say that not every study finds a correlation in that regard. He also found that fatigue correlated with depression, but on the other hand, the sleepiness, excessive daytime sleepiness, didn't really correlate with any of these other factors. Moving on, this is a bigger survey. Dr. Maida in Japan did a survey of 1,021 Japanese Parkinson patients from 35 medical centers. He also excluded people with dementia. Now, this was a study of the non-motor aspects of Parkinson. It was just getting a lot of attention at that time. So he decided arbitrarily he had to have at least one non-motor problem. And he also decided he wanted people that have problems with wearing off, that the pills don't last long enough. I'm not sure why he added that feature, but in doing so, he's mainly looking at people that have had the disease for a few years, and they're at least moderate in severity. And what he found, the non-motor problems correlated with the motor difficulty. They were common. Number one on the list was constipation. 85% of people had that problem. Fatigue was a close second, 75%, just slightly more in women than in men. If you look at the bottom, excessive daytime sleepiness, almost as much as fatigue, 72%. Another Asian study done by Ding in China in 2017, 104 Chinese Parkinson patients, and he excluded people if they had cognitive issues or other severe medical illnesses where they're having organ failure. And again, this is a study of the non-motor aspects of Parkinson's. Amongst those, he found that 42% had a major issue with fatigue. He found it correlated with daytime sleepiness, anxiety, and depression. And if we look at this little graph of his results, R refers to the correlation coefficient. So that tells you how much two things tend to occur along with each other. If there was a complete agreement, the two always go hand in hand, the correlation coefficient would be 1. If they're completely independent of each other, it would be 0. Things that are fairly strongly associated generally will have an R value of 0.7 to 1. So if we look here, The Hone and Yar stage, the number is almost zero, no correlation. This is the motor scale, the DRS3, again, no correlation. There is a correlation with the Hamilton Depression score, 26%, the anxiety score, 27%, and this is the Epworth sleeping score. So there is some correlation, but gee, it's not really strongly associated. Suggests really that fatigue is its own factor. It's not just an offshoot of some of these other problems. Moving now to the United Kingdom. This was a study in 2018 by Dr. Agarwal, and he looked at 130 Parkinson Society members in a portion of Southern England. About 3/4 of the people that he sent the survey out to responded. That's always a problem with surveys because not everybody responds. 63% reported frequent fatigue, 23% said it was a problem for them sometimes, 10% said rarely. We found it was most severe in the early afternoon, but also in the evening, so it really jives with what Dr. Van Halen had found. They looked a little further. Compared those people who said it happened frequently versus those who said sometimes. They found that it was not affected by age or years since the diagnosis. It was a little more common in women and really impacted their activities of daily living. Another British study, I found this one particularly interesting. It's by Schrag. And what's interesting about it is he's looking at early signs in Parkinson's before the movement or motor problems. Some of them several years before these motor aspects occurred. And this was a prospective registry. So people followed from 96 to 2012, 8,000 plus people with Parkinson's, 46,000 controls. Prospective is important. So when we look at data in studies, it's collected as time goes along. Done each year, you fill in some information. That's called prospective. It's more likely to be accurate than coming along to someone in 2012 and asking, can you remember 10, 20 years ago, was fatigue an issue for you? Was constipation an issue for you? And so it's more likely to be accurate recall. So what did they find? More graphs here, but if you look at this, the red, those are the people with Parkinson's. These are the non-Parkinson controls. This would be the year where they were diagnosed, where they had the movement problem sufficient to make the diagnosis. Get my arrow back, this would be 1 year before, 2 years before, and so on. So you see that constipation is there and an issue in a fair number of people long before they're diagnosed. Fatigue almost as much. Only 5 years before the diagnosis, they're having much more fatigue issues than the controls. To a somewhat lesser extent, dizziness and hypotension tend to go hand in hand with their low blood pressure issues. They also tend to antedate the diagnosis, and a little bit the urinary dysfunction and overactive bladder. Depression and anxiety, somewhat, although it's only a couple of years before the diagnosis where it sort of creeps up to higher incidences. So what do we make of that? The fact that it occurs, fatigue occurs, and these other non-motor aspects long before the movement problem suggests that it's part of the disease process itself. It's not just an offshoot of sleeping poorly because you have Parkinson's or that your muscles are inefficient because they're stiff and slow. So what does research tell us about the phenomenon of fatigue? Unfortunately, most of the work has been done on the peripheral nervous system, which refers to your peripheral nerves and muscles. I say unfortunately because in Parkinson's, the pathology, the vast majority of it is in the central nervous system, or CNS, which basically is your brain and spinal cord. I guess the reason they study in the peripheral system is because it's a whole lot easier to do and to access. So what did they find? Well, a number of things. This is a busy slide, I apologize. But one thing they found is that when you continue to do a muscle activity for a long stretch of time, muscle fatigue starts to hurt it runs out of oxygen and the fuel in the form of glucose or glycogen, and something called lactic acid builds up. Energy-containing molecules like ATP and CK, they drop down because they're used up. And there's a problem with releasing calcium into the muscle fiber, which helps the actual muscle contraction. As a result of that, our brain says, gee, we're not generating the same force. That's not what we want. So to try to compensate, the brain, through the peripheral nerve, sends an increasing number and intensity of messages on the nerve to tell the muscle to contract. We're trying to compensate. And we speculate that this overactivity on the part of the nerve is probably perceived by the brain as fatigue. One positive thing I can say is that a number of these things improve somewhat the peripheral problems of fatigue with exercise. So our muscles become more adept at using oxygen, they have more oxidative enzymes. The muscle fiber size increases, so it can generate more force with less firing, and the blood supply improves. So that's at least one aspect of fatigue that anybody can improve on. Turning now to the central nervous system, where we think most of the problem is in Parkinson's, there's a lot less data. And certainly, the studies that we've reviewed suggest that fatigue in Parkinson's isn't just muscle fatigue, although it may be a contributor. One thing we might speculate on, the peripheral nervous system suggests that excessive nerve activity is perceived by or contributes to the feeling of fatigue. That happens in the peripheral nerves. Well, lo and behold, there is some evidence that similar sorts of things happen with motor nerves in the central nervous system in Parkinson's. So one way of studying that, you may have heard of something called transcranial magnetic stimulation. Basically, they put a magnet over the scalp, over the motor control area of the frontal lobes, and the magnetic pulse triggers the nerve to discharge, sends a message down to the nerve in the muscle, and the muscle contracts. And you can measure the activity as electrically as something called the motor evoked potential. Well, lo and behold, these potentials are bigger in Parkinson's. It's like they're working overtime to try to compensate. That's not the only change that occurs in cortical motor nerves. There are a number of other things that suggest they're more electrically irritable in people who have Parkinson's. An interesting study looking at some aspects of this was done by Liu in 2003. This was a fairly small study, unfortunately, but still interesting. He had 9 people with Parkinson's, mild to moderate disease, and controls, and he used this same magnetic stimulator, measured the motor evoked potential, while he was having people do repetitive exercises with their wrist. And he looked at them one day off their medication and another day when they were taking their medication. So the top one is where they were not using the medication, levodopa, that's the active ingredient in levocarbamide. And if we look over here on the left, this group, that's the Parkinson people. These are the controls. This is at rest, baseline, and you see that the muscles and the nerves are working overtime in Parkinson's. When the person exercises, the difference persists, it's even worse, and as they're recovering from exercise. On the other hand, when they have their medication on board, at baseline, the difference is pretty much gone. There's still more activity in the Parkinson nerves and muscles during exercise and during recovery, but not as substantial as it is off treatment. Sorry about that. So at least one aspect of fatigue can actually be helped by your medication. Unfortunately, though, our observations over the last 20 years or so is that the Parkinson pills certainly don't cure the problem of fatigue. And if they have an impact, it's rather marginal, and probably because central fatigue is a whole lot more than just plain muscle fatigue. Let's move on now to sleep problems in Parkinson's. So sleep disturbance and sleepiness have both been shown to be an issue in people with fatigue and Parkinson's. And it's certainly common sense also tells us this is a logical contributor to fatigue. Well, it turns out there's a lot of reasons why people with Parkinson's don't always get a decent night's sleep. This is a daunting list, but all of these occur with an increased incidence of people with Parkinson's. Now, I don't mean to say that you're going to get every single one of these or necessarily any one of them, but unfortunately, each of them is a slightly higher incidence if you have Parkinson's. So just read down the list: trouble getting to sleep in the first place, staying awake because of frequent awakening, excessive daytime sleepiness. When that's fairly bad, even something called sleep attacks, the person just nods off mid-activity, maybe the middle of a meal or during a conversation. That's sort of the ultimate, the nth degree of EDS. Something called the restless leg syndrome, which is common in the general population, but a little more common in Parkinson's. Periodic leg movements. So these are sort of slow up and down flexion movements of the knee and the hip repetitively while you're asleep. Sleep myoclonus, where it's a single muscle jerk. It's really only an issue if it wakes you up. Muscle cramping, having to get up to the bathroom during the night. Something called the REM Behavioral Disorder, and we'll talk about that in a little more detail later. Vivid dreams, nightmares, rarely sleepwalking, and a common thing called obstructive sleep apnea. Again, you don't have to have Parkinson's to get that. This is what our nights are supposed to be like. So there are two major types of sleep: REM, rapid eye movement sleep, where we're dreaming, and non-REM. And typically, in a typical night, hopefully this arrow is showing, we start in the light stage of sleep. We go through 4 stages of deeper sleep. Then we convert to REM sleep. And every 60 to 90 minutes, we repeat that cycle. And generally, there are 3 or 4 of them in a normal night. The REM sleep and the deepest stages are probably the most important for functional recovery. If you're having frequent awakening, you're going to spend a lot more of your time in the light stages of sleep and hardly ever get down here or to the REM stage. So what can we do about this? For starters, you can try to improve, maybe easier said than done, try to improve sleep hygiene. And we know that if you're fairly consistent of your timing for when you try to go to bed, that helps. Having similar routines each time. Trying to avoid anything too stimulating in the late evening. And avoiding blue light. That's a more recent topic of discussion, but blue light apparently suppresses melatonin and makes it harder for us to get to sleep. And many of our electronic devices have light that contains a fair amount of blue light. So try to avoid your electronic devices for the last couple of hours before bed. Not too much in the way of caffeine or stimulants after supper. Watch your fluid intake in the evening. And even if you don't feel the need, go to the bathroom before you retire from the night. If it turns out that you're having problems getting to sleep because it's hard to get comfortable, turn over in bed, or other reasons why you may have difficulty. But if that's the issue, then I generally recommend to people take one of your medication doses just before bedtime. Don't routinely advise that in all situations, but if it's hard to turn over or tremors keeping you awake, this can help. The problem is turning over. You can reduce the friction, the resistance to turning over if you use smooth things like silk or satin sheets or pajamas. So allow yourself the odd luxury. If you happen to have restless leg syndrome as well, turns out that iron deficiency, common issue, unrelated to Parkinson's, that tends to aggravate restless legs. So if you have it, drop it. And if it's bad enough, there are medications that can help. Mirapex, which is the agonist called pramipexole, Requip, which is Repinerol, clonazepam, and gabapentin all have some effectiveness. Sleep myoclonus, I don't generally say take anything for it, but if these are really major movements and they're waking you up, then amitriptyline, clonazepam, and baclofen are all medications that will occasionally, actually fairly often, help. If the issue is muscle cramping in bed and stretching just before you go to bed, baclofen calcium, magnesium supplements, and quinine can all help. The starting point generally isn't a prescription for one of the pharmaceuticals. Do the stretching routine, try the mineral supplements before bedtime, and only consider the others if it's still an ongoing issue. An overactive bladder, goes all out. There are a number of medications that can help to reduce that to a certain extent. And also common sense, not too many liquids. Good fluid intake is important and a good thing, but get it all in by supper. Depression, so sleep is often disturbed in depression, and early morning awakening is a very common feature of depression. If it's there, try to treat it. There are a number of medication options or counseling or combination. Nightmares and hallucinations. These aren't always due to medication. Very often, unfortunately, they can be induced by the Parkinson medications. So use the lowest dose necessary of your meds, especially the evening dose, because that will lead to the highest blood level while you're in bed. And if it's still a major issue, thiopin and clozapine can help reduce that. And there's another one that they have in the States that we may get very shortly called class. REM Behavioral Disorder, there are treatments, as I mentioned before. Clonazepam maybe is a starting point. There are others as well, possibly melatonin. So what is the REM behavioral disorder? So it refers to abnormal disturbed REM sleep. Normally in REM, we're completely motionless except that we're breathing, and our eyes move under our eyelids, and we're dreaming. In this behavioral disorder, there's some sort of disconnect. So the person is actually moving their limbs, sometimes quite wildly, they're often talking or mumbling. Sometimes they'll sleepwalk or fall in bed. And this can be a real issue. Sometimes it leads to injuries. You hit your arm on the corner of the night table, knock the lamp over, or the spouse is at risk as well there. So it's something to consider is unfortunately separate beds, or maybe before that, just safety issues. Move the lamp back a bit, move the corner of the night table back a bit so your hand isn't hitting it as it swings around during the night. This is a very common thing in Parkinson's. About a third to a half of people get it, and often even before they have a diagnosis. If you have this and you're a family member, don't panic. It's not like everybody with the REM behavioral disorder goes on to get Parkinson's. You can also avoid aggravators, alcohol, the type of antidepressant called serotonin selective reuptake inhibitor, or tricyclic antidepressant. Those are aggravators. As I said before, clonazepam and melatonin sometimes help. The literature is a little hazier here, but possibly Mirapex and Weep that can help a bit as well for the REM behavior disorder. So, what can we do for fatigue and Parkinson's? For starters, even though these may not be the main reason why you have fatigue is probably a central part of the disease process. These are at least things that almost certainly contribute somewhat to the fatigue, and there's something we can impact. So do your best to treat sleep disturbance. It can be a challenge, but there are a number of things that we've mentioned that can be done. If depression is present, treat it. Look into your medications. There's some aggravating medications there. Getting things down to just the necessary. And lack of exercise. That's something you can do something about. So let's look at these in a little more detail. Oh, I should also mention, it's worth getting sort of a general medical history and physical from your family doctor or internist. Just because you have Parkinson's doesn't mean you're guaranteed you can't get something else. So anemia, thyroid problems that can sort of aggravate fatigue. If you have obstructive sleep apnea, we can do something about that can cause fatigue in and of itself. So depression, come back to that. very common in Parkinson's. We think that the dopamine deficiency in this disease predisposes to this occurring. The prevalence is about 30%, meaning that over the course of the illness, about 30% of people with Parkinson's will have depression as an issue. And it's worth noting also that it's not always obvious. It doesn't mean it's not synonymous with feeling sad or cheerful, although that can be an occurrence. It can be very frequent. It can be masked, in other words. Sometimes the tip-off is if it's altered your sleep patterns, a feeling of apathy, changes in appetite, cognitive issues, it's harder to concentrate with depression, and fatigue. Exercise in Parkinson's. Increasingly, we're recognizing that exercise is important in Parkinson's. Quite apart from having Parkinson's, if anyone has an injury or a serious illness and they're in bed for a couple of weeks, it's amazing how quickly our muscles get weaker and they fatigue more rapidly. We decondition. So even though that's not the main reason that you get fatigue in Parkinson's, you can minimize that by being active. Unfortunately, there's not a whole lot of data there. We are starting to see some controlled studies, short-term ones, with this modality in Parkinson's, and they've shown improvement in muscle strength, better walking, improvement in several quality of life skills. But I don't believe in looking through this that fatigue has been specifically studied. Nevertheless, logic tells us that it's very likely fatigue would also be improved by an exercise program. Interestingly, one study showed that the abnormal motor evoked potential I talked about and was part of that Lou study we discussed, that actually can improve with exercise. So what medications should you reconsider, or at least take a close look at? A number of medications can aggravate or cause sleepiness or fatigue. Obvious culprits, tranquilizers, sedative medications, sleeping pills, particularly long-acting ones. The short-acting ones aren't so much an issue. And occasionally, some antidepressants, some painkillers cause or aggravate fatigue. Unfortunately, sometimes the Parkinson pills themselves are aggravators as well. In particular, the ones that go directly to dopamine receptors are called dopamine agonists, and we have 3 of them available in Canada at present. Mirofex, that's pramipexole. Requip, that's propinerol. And in about 15% of people taking these, they report a worsening of fatigue. The same thing can happen with levodopa, but it's usually much less severe, and it's in about 10% of cases. So using the lowest dose that's necessary. On the other hand, some Parkinson pills might actually be a little bit beneficial. Amantadine is fairly widely used in Parkinson's. It's an add-on medication. It helps along with your levocarb or other medications and motor dysfunction. And in particular, it helps suppress those involuntary movements called dyskinesia. And the reason I mentioned it in regard to fatigue, it turns out that it's very helpful for MS patients with fatigue. About 2/3 of them report quite an improvement in fatigue with amantadine. So I've used it in a number of my patients, and although I have had some people say it helped modestly, it's been kind of disappointing. It's certainly not a huge success in Parkinson's. It doesn't seem to work as well for fatigue as it does in MS. I mentioned that there were 3 dopamine agonists. We talked about Mirofex and Requip. Well, the third one, the most recent one, is the patch, the rotigotine patch, also known as Nupro. What's different about it? It goes to a receptor called D1, whereas the others do D2 and D3. D2 seems to be most crucial for the movement problem. D3 we don't understand all that well, but has some issues with mood. So D1, in an animal model of Parkinson's, was a strikingly big help. So this is a model where some unfortunate monkeys are given something called MPTP. MPTP is a selective nerve toxin for dopamine neurons, and it's our best animal model for Parkinson's these days. So they gave the monkeys MPTP and made them Parkinsonian, and then they studied fatigue. So as you can figure, they can't exactly give the monkey a questionnaire and say, "Have you been tired or sleepier today?" They decided what they would look at is the percentage of the daytime hours when the monkey was napping. And they could also measure the amount that was REM sleep because they could see the eye movements. So this is baseline. It's their usual napping in the daytime before they're made Parkinsonian. This is after they're made Parkinsonian. So they're sleepier, they spend more of the day napping. And the next bar over, the black one, is a few months later when it's more chronic, this one. And this is after they're treated with an agonist kind of like Mirapex. It's called Peripheral. It's selective for D2. It's not something we use clinically, and it improves the motor function of the massage monkey. But it didn't improve sleepiness. Actually, if anything, made it a little worse here than what they were like there. On the other hand, this one, the D1, called SKF3893, don't worry about that. But it's selective for D1, even more selective than Nupro patch. We're not going to see it clinically because it has other unwanted side effects with it. And it actually improved the daytime sleepiness. And if you look at the REM sleep, which diminishes when they're made Parkinsonian, it got even a little worse with D2 agonists, but D1 got it back to the baseline. So it's possible that D1 agonists in the future might be something we can reach for to actually help with fatigue. From sort of theoretical considerations, it's been postulated that if you can get a steadier stimulation, steadier blood level of dopamine, stimulation of the receptors, that might help fatigue. And indeed, our experience with something called the Duodopa pump tends to corroborate that. So the Duodopa pump is certainly something that is very helpful for people who have marked fluctuations called wearing off or on off. It can also help regulate and streamline things in people who have severe dyskinesia. We use it sometimes when they have those issues, but DBS surgery is contraindicated for some other reason. The Duodopa pump is actually a gel form of levodopa, which is put into a container and pumped in through a tube past the stomach and into the intestine. And so it's absorbed right. So you have a tube there all the time. So it's a pretty major undertaking, and only a select number of people have enough issues to warrant getting it. So it turns out the Duodopa really helps for wearing off and to diminish dyskinesia. But in this study, they looked at other issues going on. So this is the person at baseline, and here's after they've got the pump. So all of these things improve. And if you look down here, the purple line is sleepiness. So it improves on the pump, and they maintain that for a full 24 months on the pump. That's how far the study went. Similar improvements were seen with mood as well. Not quite as convincing, but a number of these other non-motor features seem somewhat improved with the steady stimulation of the levodopa that you get with the Duodopa pump. Another approach is to reach for a stimulant drug. This sometimes helps a bit, but maybe not as much as I might have expected or we hoped for. Ritalin, which is also called methylphenidate, sometimes helps modestly, and dextroamphetamine, also known as Dexedrine, likewise. However, you have to be careful about the dose, and you have to make sure you take it in the first half of the day, otherwise it tends to aggravate insomnia. In some people, these drugs, these stimulants can cause anxiety or heart palpitations. Another very simple thing to do is consider coffee. So I'm hoping that you can see all this and it's not cut off by the box on the side like it is on my screen. But coffee is interesting in Parkinson's. It turns out that it has at least some protective effect, stopping people from getting it, or at least delaying the onset. And now they're finding it also has a modest positive effect in some of the symptoms when you already have Parkinson's. So this was a study, a pilot study of caffeine capsules, 400 milligrams, which is the equivalent of 3 to 4 cups of coffee a day. And what they found here, if we look down here, UPDRS3 is the movement problem. These are people getting inactive placebo pills rather than caffeine. They also agreed not to have the regular coffee, just the capsules. And the red is the people taking the active caffeine. And you can see that the mood improves. The sleepiness, they use the Epworth sleepiness scale, and there's a trend towards it being better with caffeine without, although this isn't quite enough of a separation to be statistically significant. Same thing pertained in an overall scale called the clinical general impression. Excuse me, I'm not exactly sure what those letters stand for. However, the word pilot study tells us that it was a small study, not quite enough people, and not long enough follow-up to really be definitive. So this needs more work to be corroborated, but it certainly suggests that coffee is something to consider in modest doses if you have fatigue, and perhaps also for the motor dysfunction. On the other hand, for personal experience, I can tell you if you overdo it, you tend to crash a few hours later. If you have an overactive bladder, then high doses of coffee and caffeine make you pay in other ways. So, by way of summary, what can you do? I suggest seeing your general doctor and getting a general medical assessment, make sure there's not some other physical issue that's adding to the problem. That may be some lab test screening, your blood counts and your thyroid. And if you're a prominent snorer or waking up with headaches, maybe getting a sleep study, a referral to find out if you have obstructive sleep apnea. Even though Parkinson fatigue, I've argued, is probably mainly due to some not all that well understood simple factor, it's still worth optimizing culprits that are manageable that aggravate fatigue. So look into the possibility of medication side effects, sleep disturbance, lack of exercise. Those are all things you can do something about. But please consider the possibility of depression, and if it's there, a trial of treatment. And lastly, if still an issue, consider a trial of supplemental medications that might aid fatigue, including caffeine and moderation. And that's the end of my presentation. I'd be happy to try to answer questions that you have. I'm not sure whether the audio is going to allow that, but we'll see what happens here.